Dr. Sharma, thank you so much. That was exhaustive and a wonderful deliberations. I'm sure our audience have a lot of questions. Let Dr. Kelvin Lee now moderate the session. He's an advanced endoscopy doctor. Dr. Lee, please proceed forward.
Excellent. Dr. Sadapathy, I would request that you look at the chat because I can't actually see that while I'm looking at you.
Yeah, sure, of course. I'll look through the search at the chat buttons as well. No problem.
Dr. Sharma, that was an excellent talk. I really appreciate it, and I learned a lot from it. I guess I will ask, start from the back, actually, and start about the rectal cancer staging. So I get referrals only from colorectal surgeons sometimes for EUS staging of rectal cancers after MRI. You said that it should always be done. And I think of it as EUS and MRI are complementary. So I always do it when I get the referral. So how would you discuss the test characteristics of MRI and EUS with the surgeons and oncologists to try to convince them of the role of EUS?
I think, unfortunately, the center where I work in, we do not have a long surgical backup, we don't have a tumor board. So I still do not have the wonderful setup where there is ultrasound, endoscopic ultrasound, CT, MRI, PET, surgery, then histology and tumor board where we have guns blazing. Who was wrong? Who was wrong? Who did not do a proper job? So the answer to this question is better done by a person who is experienced in this kind of thing. So my question is, Shika, I would like to do a passionate EUS imaging, chat box. I would like to do a passionate imaging, that's all. And then whatever comes, by that fascinating imaging, I will give it to the surgeon, and that surgeon can decide whatever he wants to do about it.
Excuse me. Okay. I have a question from the chat box, actually. Dr. Bikramjit Mitra, if you want to ask the question yourself, Dr. Mitra.
Yeah, the question is if PET positive for METs in esophageal cancer, would you still proceed with EUS in your practice? Okay. The question is, I always ask, what do the patient want? The question is not for me. It is PET positive. What do you want to do? PET positive for METs in esophagus cancer. Where are the METs? Where are the METs? Is the surgeon thinking of downstaging? Probably, in this case, as Vikram has said, there may be no indication of proceeding with esophageal cancer. However, the question is, who did PET before doing EUS? Because mediastinal invasion is best diagnosed. So when you're doing a CT scan, you're going to decide CT scan, what exactly is your purpose? Because the algorithm will change in each case. Algorithm. If this is a MAT and you want to downstage, you want to restage, then you can as well as pre-stage before going on to restage the same case. So you cannot cut boundaries. You cannot have clear-cut categorical boxes because the modalities are so many and these modalities have opened up a Pandora box.
Thank you. I think we have one more question from Dr. Gupta, Rohit Gupta.
Can I ask to that last question? Sorry, I'm
yes,
driving.
Please go ahead. Yes, please, Dr. Gupta,
yes,
go ahead.
I'm actually from the UK. Basically, sir, in our practice, in the MDT, after the CT shows no definite metastasis anywhere, they will do a PET CT, the surgeons. And if the PET CT shows, for example, if it's a distal esophageal cancer, and if the PET CT shows some PET positive lymph nodes higher up in the cervical area, so they will consider it as a metastatic disease and they will proceed with some chemo first before taking them to surgery or sometimes US biopsy. The category which we do here more commonly is where the PET CT is negative and the surgeons want to be absolutely sure that before going in, there are no small lymph nodes which may appear like a malignant disease somewhere else, which can be biopsied. So that's how we. Thank you.
I think your voice was kind of muffling. I don't know how much you got, Dr. Sharma. You got the question correctly? Dr. Sharma, you got the questions
I got the
correctly?
question. I got the see.
Yeah.
See, there is no algorithm today. What happens? This chemoradiation has disturbed everyone. These people, they form their own protocols. To each his own. So there is no standard protocol today, I believe, to do PET. I have not heard of MRI as a common. MRI esophageal cancer, no. MRI gastric cancer, no. MRI rectal cancer, yes. Then MRI, they do. Now, what happens? My job is to give my imaging findings.
पेशेंट है तो भेजना
Yeah, Rohit, your question is there.
Yeah, we have a question from Dr. Gupta, which is
Yeah.
Rohit Gupta. Will you do US for rectal cancer when you diagnose rectal cancer on endoscopy, or will you do US after CT and MRI?
I am a gastroenterologist. I love doing my job. I love staging everything. And for example, at my center, for esophageal cancer, what I do, esophageal cancer, in my case, what I do, I will put in a endoscopy, I'll put in a US scope. If it is heavy mediastinal invasion, then why? Maybe PET may be done plus minus, send the patient for chemoradiation. So they insist because the PET people, chemoradiation people are used to having PET CT, they will do it. But mediastinal invasion I have diagnosed, it is in. Now what about rectal cancer? As I said, everything is a Pandora box. This chemoradiation has disturbed the algorithm in a big manner for everyone. The surgeon is waiting for with his knife and all, but this suddenly the staging changes. So whatever changes the staging, whatever gives appropriate staging, that modality must be done. And I cannot be ruled out of staging modality because I will always make a difference by endoscopic ultrasound.
Thank you. Calvin, you want to?
Yeah, I agree. Actually, there's a very big role, a very big opportunity for rectal cancer to be staged complementary by both MRI and EUS. The EUS is, as you pointed out in your talk, much better for those small lymph nodes which are never normal. So you gave an example where you biopsied one and proved it. If you never even biopsied it, could you say that they are malignant just because they're not supposed to be there?
Dr. Sharma, you want to respond?
There is CT and MRI show rectal cancer with no spread. Rectal cancer always. As I said, will you then proceed with the US? Rectal cancer always because it changes. I said, why I am so passionate, esophageal cancer, gastric cancer, luminal cancer, EUS will change, may change the staging. EUS, I can tell you whatever CT has shown, whatever MRI has shown, if it is going for surgery, oh, no, don't pick up your knife. Let me do the US staging first. However, if you are going for chemoradiation, then okay, I can withdraw myself. You are not going to operate. But if you are going to operate, no, let me use my below first.
You
That's what I try
biopsy,
to
right?
advocate. Difficult to convince surgeons and radiologists. So that's,
Yeah.
I think Dr. Jasprit Singh is here still, or no? He just left, I think.
Can you comment on the role of EUS in gastric cancer with kind of a more infiltrative spread like Laminitis plastica? Some
As I said,
surgeons ask us to try and define exactly where it is because it may be infiltrating underneath the surface.
see, in gastric cancer, as I said, the lymph nodes we have picked up, surgeons were going to operate, we have picked up, and they said, let me do EUS. And sure enough, when I did on EUS, I was able to tell that this lymph node is not a perigastric lymph node. This lymph node is in a mesentery along the superior mesenteric artery. So please think of what you are going to operate about, think of your staging. So we will always make impact. When we are allowed, the question is the CT scan, and sometimes, sorry to the surgeons are so, they underestimate our ability so much. They always say, no, I'm not going to make a difference, that they don't give us a chance. Give me a chance. I will prove myself. And I can dare. I will prove myself better in tumor board meeting if you are going to operate. Let me do a staging of nodes. If you are going to do surgery in gastric cancer, however, this concept is very difficult because you have to be, cannot say that concord. You have to be really passionate about proper staging of each lymph node when you are going to operate upon a case of gastric cancer.
Dr. Singh, looks like you want to ask a question. You have to unmute yourself first.
It's been a wonderful presentation, masterly presentation. And I don't think I have any questions, obviously. It's almost, cutting edge. We don't know. What we gather from his talk is that in future, endo ultrasound is going to change the, the algorithm of management of all the luminal malignancies. That's all I can say. And he's so passionately and he's so boldly asserting that's a revelation.
Thank you. And also I see that Dr. Rajkumar has also a great appreciation on your talk. Your masterclass on EUS was incredibly informative and well delivered. I truly appreciate the depth of knowledge you shared and how effectively you communicated complex concepts. Thank you for your expertise and dedication to educating others in the field. So thank you, Dr. Sharma, for that wonderful deliberation. Again, audience, if you have any questions, please raise your hands or switch on your videos so we can understand that you are about to ask a question. In the meanwhile, Dr. Kelvin Lee, please proceed, continue to generate the questions and the discussion.
Excellent. You mentioned this point in the staging of esophageal cancer portion of your talk. So the subcarinal lymph nodes, how, when you look at it, how do you differentiate a benign appearing versus malignant appearing? And do you have to sample things that are questionable?
That is a very interesting question, and I would like to elaborate upon this. People in CT scan, when they do lymph node, these CT scan people always look at one thing, size of the lymph node. And then there is a cadaveric study of GIADE which has shown the normal size of lymph node in subcarinal area can be up to 2.5 centimeter. Then the normal area in the right paratracheal centimeter again can be 2.5, 2 to 2.5 centimeter. And since lymphatic drainage happens more in subcarinal area and on the right paratracheal area, the large lymph node. So where is important? The sub-centimeter is important. So when it comes to EUS of lymph node, we are important because it is not the size. CT scan is telling you only the size. We are telling you about the border, the hypoechoic area, the vascular center of the lymph node, whether the lymph node, because of infiltration, is getting rounded and it has lost its hyperechoic center, lymph node is confluent, lymph node is merging. So even a small 4 millimeter rounded node is pathological, and a 2.5 centimeter subcarinal lymph node is non-pathological. And then I'm adding elastography on it. Which part of the lymph node? It is not a single lymph node. I'm going to take FNAC of a part of lymph node. I'm going to characterize the lymph node in detail. And this lymph node, this part, PET has shown this part, but no, this is the hypoechoic part. I am going to take liquefied part, hypoechoic part, 2 centimeter node versus a 5 millimeter node. In a celiac node, if it is a 5 millimeter node, I will do FNAC of that node. VCT may have missed. So characterization of node by endoscopic ultrasound is much, much superior. So nodal staging, they just count numbers. I think I have answered my question.
I completely agree with you. Everything is by size and location, but not characteristic on the cross-sectional imaging. So the EUS does give you much more detail and the ability to sample. So thank you. Another question: do you advocate for, and I think that you've already answered this in your talk, for early gastric cancer? So where you might actually have the ability to either perform or refer for endoscopic submucosal dissection. Do you always do the EUS first, and then if you don't do it, like I do not do EUS, ESD, I do EUS. Do you like to have the ESD person do both, or do you do it first and then send it to the ESD person?
No, unfortunately, we do not have the facility of EUSD. And unfortunately, we have not yet started picking up the early gastric cancer, which have been told by people in India that it is as common as in Japan, as a recent study has found. So unfortunately, Indians have not got the mindset yet of a proper screening for early gastric cancer. I'm sure it is here, it is there, and we have to start modifying our practice to pick up these early gastric cancers.
Yeah, definitely the Asians have much more experience, and because in the US we have pockets of large Asian population, we certainly have certain places.
Role of EUS prior to detection making of ESD EMR. Okay, so this does not conform to the topic, but I will still answer. See, when you are an EUS man, the indications will evolve. When I started my practice, I was being laughed at. Why are you doing EUS for such bleedings? So when I did the bleeding, I found that there were hidden varices, endoscopically inevident varices, endoscopically inevident rectal varices, endoscopically inevident fundal varices. Then I was trying to find the flow of the varices. So when you're doing EUS with a passion, the indications will evolve. Hemosuccus pancreaticus, we found flow of signal into the pancreatic duct. So when you're doing EUS prior to decision making of ESD, just now, what happens? There are ESD people, and these ESD people, they just think of themselves as the last word. They are going to do about it. We don't want any interference but I personally cannot allow any ESD before proceeding through EUS, especially if the tumor is large. Nothing, no way. I will say what the positive predictive value of their diagnosis on endoscopic vision will not be more than 60%. I increase the positive predictive value of possible lesion, that this is this, to 90%. So EUS must be done. One small thing about a luminal cancer. I saw in a conference long back an ampulloma being removed by sneer. I can say I'm sorry to say, I was aghast. Because to me, you cannot resect an ampuloma without EUS. Because you have to see if there is slight infiltration of pancreatic duct or not. And this cannot be told without. So when you see things, do not believe what is written in the books. What is written in the books is there to discourage. Who has done 100 US ampuloma studies? Has anybody done it? Who has done a pre-endoscopic correlation, ESD correlation, histological correlation in a tumor board meeting? Nobody has done it. The surgeons, ESD people didn't want to do it. You to do it because you may tell them, don't do it. Or you may tell them, modify your way. This is a full thickness tumor. So there is no rules. I cannot say role of EUS. I will do every time I've got an opportunity. Unfortunately, insurance has a role to play. And man-made algorithms have got a role to play. But the right to break the algorithm, it does not belong only to the chemoradiation people. Even we have a voice. We as endosonographers should have a voice. And we should raise it.
Thank you, sir.
If there are no other questions, Dr. Lee, you want to wind up? No, there is one. There is no other questions.
All right. I think you've, Dr. Sharma, you've made the point that an expert endosonographer can always add value by performing a test, which is, to be fair, a lot less risky than surgery or some of the other treatment modalities. It's considered a low risk test that has some possibility of changing management. So I think that your argument that you can provide a lot of value is a very, very valid one. I think your value that you provide also is much, much more than someone that does a very low volume. So I think sometimes the guidelines are written in such a way that the average endosonographer with the benefits and risks in alternative testing can fit into those algorithms. But if you argue for the best individual testing for the best individual treatment, I think that your argument definitely is valid.
Yes.
Thank you. Thank you. Thank you to both. Thank you, Dr. Sharma and Dr. Lee, and for this wonderful discussion. This is a very exhaustive talk going from the esophagus to the stomach and the rectum. I don't think you'll find this exhaustive lecture in any conference because you have to be limiting yourself to 20 minutes. So you're getting from one of the best the whole concept of the luminal cancer evaluation by US. If anyone has missed this lecture, I believe with the permission of Dr. Sharma, we'll put it on our website and anybody, they can come back and listen to this talk and learn about it. So again, I would like to thank everyone and both of you, Dr. Sharma and Dr. Lee, for joining us today and taking some time from your own work and disseminating this knowledge to the world. Thank you.